The topic of discussion is gingiva. Before getting into the actual topic, I want you all to know two basic terminologies. The first one is the periodontium and the second one is the oral mucosa. The periodontium comprises of four principal components. They are the gingiva, periodontal ligament, cementum and the alveolar bone. All these four components are distinct in their location, architecture, and composition, be it biochemical or chemical, but ultimately all of these will function together as a single unit and they will maintain the support that is necessary for the tooth to get retained in the oral cavity. Let's add some more information here. The gingiva and periodontal ligament comprise the soft tissue components, that is the fibrous connective tissue components, whereas the cementum and alveolar bone comprise the hard tissue components, that is the mineralized connective tissue compartments. Now, in this diagram, I want you all to appreciate the different locations of different periodontal compartments. We have the lining around the tooth root surface, which is called as cementum. Connecting the cementum to the alveolar bone, we have the periodontal ligament fibers. And surrounding the alveolar bone, we have the gingiva, which is divided into three zones, which we will be seeing later. Though they are different in their location, but ultimately they function as a single unit and maintain the support for the teeth. And these components are so important that if suppose one of the component gets affected, the other components also will get affected by it, thus hampering the maintenance, repair and regeneration of the periodontium. Now we will learn what oral mucosa is. Oral mucosa is the lining of the oral cavity. It is divided histologically into three zones. The first one is the masticatory mucosa, which covers the gingiva and the hard palate. The second one is the specialized mucosa, which covers the dorsum of the tongue. And the third mucosa is the one that lines the rest of the oral cavity other than the above two categories. So the hard palate is covered by masticatory mucosa, you can see in the picture, whereas the dorsum of the tongue is covered by the specialized mucosa. The topic of concern today, that is the gingiva, is covered by masticatory type of mucosa. Now we get into the actual topic, that is the gingiva. Before starting with this, we will learn the definition of the gingiva. Now don't worry at this point, be with me and we will learn the definition together. The first part of the definition is it's a part of oral mucosa. Don't we all know this? We have already learned that the gingiva is a part of masticatory mucosa. The second part of the definition is that it covers the alveolar process of the jaws. In the first diagram we have seen that there is cementum, periodontal ligament, alveolar bone and surrounding it we have the gingiva. So yes, it covers the alveolar process of the jaws and it surrounds the necks of the teeth. You can see in the picture that the gingiva is nicely adapted onto the tooth surfaces. But the gingiva does not exactly end at the neck of the teeth, that is the cemento-enamel junction of the teeth, but it ends 0.5 to 1 mm coronal to the cemento-enamel junction. Now let's repeat the definition. It's a part of oral mucosa that covers the alveolar process of the jaws and surrounds the necks of the teeth. Now we will learn the clinical features or the macroscopic anatomy of the gingiva. By macroscopic, I mean without the aid of microscope, whatever we are seeing clinically are the clinical features or the macroscopic anatomy of the gingiva. The normal gingiva covers the alveolar bone. We already know this, and it covers the tooth root to a level just coronal to the cemento-enamel junction. How much coronal? It is 0.5 to 1 mm coronal to the cemento-enamel junction. And anatomically, the gingiva is divided into three zones, that is the marginal gingiva, attached gingiva, and the interdental papilla. So here in the picture, we can appreciate the different parts of the gingiva. We have a V-shaped depression in between the tooth and the marginal gingiva. This V-shaped depression is called as gingival sulcus. And there we have a free or marginal gingiva. In continuation with that is the attached gingiva. In between free or marginal gingiva and the attached gingiva, we have a demarcation which is called as marginal groove. And in between attached gingiva and alveolar mucosa, we have another demarcation which is called as mucogingival line. Now we will study the individual gingiva. So getting into the marginal gingiva is also called as free or unattached gingiva. Why is it called so? Because it isn't attached to anything. On the other hand, the attached gingiva is attached firmly to the periosteum of the alveolar bone, but the marginal gingiva is free. So when you pass a periodontal probe into the gingival sulcus, you can easily separate the marginal gingiva from the tooth surface. It is called marginal gingiva as it is forming the terminal edge or the border of the gingiva. Now here I want to emphasize an important point, that is a marginal groove. The marginal groove is also called as free gingival groove. So, when I place a metallic instrument, that is my periodontal probe, into the gingival sulcus, the parameter I am measuring there is the sulcus depth. If I draw a line from the end of the sulcus depth horizontally towards outer surface, then there will be a demarcation which is called as the marginal groove or the free gingival groove. Now remember that the marginal groove is present only in 50% of the cases. According to Carranza, it is that only it is seen in 50% of the cases, whereas some other textbooks say that it is seen in one third of the cases. But for now, remember that the marginal groove is not seen in all the cases and it is seen only in 50% of the cases. And also that the presence of marginal groove does not determine whether the gingiva is healthy or diseased. It does not confer any health status. Okay, next coming to the concept of gingival zenith. The most apical point of the marginal gingival scallop is called as gingival zenith. You can notice in the picture the white arrows pointing to the most apical portion of the marginal gingiva. This gingival zenith has particular dimensions. It is 0.06 mm apicocoronally and 0.96 mm mesiodistally. Another important point I want to stress here is the gingival zenith is located distally in the central incisors, whereas it is located exactly at the center in case of lateral incisors and canines. You can even appreciate this point in the picture. Now, we will learn about the gingival sulcus. The gingival sulcus is a shallow crevice or the space around the tooth and is V-shaped. We have already learned that it is bounded by tooth on one side and the marginal gingiva on other side. Let me refine this statement. I can say that it is bounded by tooth on one side and the epithelium of the marginal gingiva on other side. It means the same. Now, I can even say another statement. I say now that the marginal gingiva is forming the gingival sulcus. It also means the same, right? The marginal gingiva is forming a part of the gingival sulcus. Now, the gingival sulcus depth is a very important diagnostic parameter. How do you take the sulcus depth? We take a metallic instrument, that is a periodontal probe, and pass it into the gingival sulcus, and whatever depth we are recording is called as the sulcus depth. In pristine conditions, that is in the germ-free conditions or in the microbiologically sterile animals, what happens is there will be no sulcus depth. The sulcus depth is 0 mm or nearly 0 mm. But this isn't possible. In the clinical conditions, we do have some amount of sulcus depth. So when the sulcus depth is measured histologically, that when we take a histologic section and see, we will notice a sulcus depth of around 1.8 mm with variation of 0 to 6 mm. Whereas when we place a periodontal probe and measure the sulcus depth, it is around 2 to 3 mm. You may ask me why there is a lot of difference in between the clinical probing depth and the histologic depth. That is because when you measure histologically, you will be able to exactly determine the epithelial attachment location. But when you measure clinically, it is not possible because the periodontal probing is dependent on a lot of factors like the diameter of the periodontal probe, the force with which the periodontal probe is being passed, and the technique which is followed during the probing. So usually what happens is when we are probing, the probe passes beyond the attachment level. So we are overestimating the depth there. So here I have stated that the probing depth is 2 to 3 mm. So what happens when the probing depth is more than 2 to 3 mm? That condition is called as periodontal pocket. It is a pathologic condition. Another point I want to emphasize here is sulcus depth measurement is an important diagnostic parameter, but it is not the primary diagnostic parameter to differentiate in between the healthy gingiva and the diseased gingiva. The sulcus depth is one of the secondary diagnostic parameter. There are many secondary diagnostic parameters, and the sulcus depth is one of the secondary diagnostic parameter to differentiate in between the healthy gingiva and the diseased gingiva. Then what is the primary diagnostic parameter? The primary diagnostic parameter is the bleeding on probing. So as you can see in the picture, we have a metallic probe which is passed into the gingival sulcus to measure the probing pocket depth. Next, coming into the attached gingiva. The attached gingiva, as we already know from the terminology, the attached gingiva is firmly bound to the underlying periosteum of alveolar bone. It is firmly attached, it is not movable, and the marginal gingiva and the attached gingiva are keratinized. Okay, so in the picture you can see that the probe, we are placing it on the facial surface of the incisor, is measuring the distance from the marginal gingiva to the mucogingival junction. So this particular measurement is called as the width of keratinized gingiva. Okay, you understand now? The marginal gingiva is also keratinized and the attached gingiva is also keratinized. So when you are asked about the width of keratinized gingiva, your answer should be the sum of the width of marginal gingiva plus width of the attached gingiva. But when you're asked about the width of attached gingiva alone, then you should measure the distance in between the marginal groove to the beginning of the mucogingival junction. In cases where there is no marginal groove, it is not usually present. In such cases, the terminal point of the marginal gingiva to the beginning of the mucogingival junction will determine the width of the attached gingiva. So when you're asked about the width of attached gingiva alone, then your answer would be width of keratinized gingiva minus the width of the marginal gingiva. How do you measure the width of the marginal gingiva here? The width of marginal gingiva is nothing but the sulcus depth. Why? We have already seen that the sulcus lining is formed by the marginal gingiva on the outer aspect. So if we measure the sulcus depth, we are indirectly measuring the width of the marginal gingiva. So measuring the sulcus depth and subtracting it from the width of keratinized gingiva gives us the width of attached gingiva. So when calculated, the width of attached gingiva is greatest in the anteriors and it is least in the posterior teeth. In the maxillary incisors, the measurement of the width of attached gingiva is 3.5 to 4.5 mm, whereas in the mandibular incisors, it is 3.3 to 3.9 mm. In the maxillary premolars, the measurement is 1.9 mm, whereas in the mandibular premolars, it is 1.8 mm. Now in this diagram, you can appreciate the mucogingival line separating the attached gingiva from alveolar mucosa. Now here, I want to state another point. The marginal gingiva and the attached gingiva are keratinized, whereas the alveolar mucosa is not keratinized. Now, the width of the attached gingiva increases with age and supraeruption. I want you all to understand this concept. With age, the teeth start getting attrited. So why is it that attrition is taking place? The teeth are in the oral cavity for a longer period of time. That is, the teeth are in the oral cavity functioning for a longer period of time. So there is attrition of the occlusal surfaces and the incisal surfaces. Once there is attrition or the loss of the tooth structure, this teeth tries to move in the occlusal surface in order to meet its opposing occlusal surface. So in this process, when it is moving, it will take the whole attachment with it. So it will take the marginal gingiva and the attached gingiva, interdental papilla along with it. In such cases, what happens? The width of attached gingiva is obviously increasing with age and with the supra eruption. So here we have an important point here. The mucogingival junction is stationary. The mucogingival junction doesn't move. Only the attached gingiva is moving along with the moving tooth. So that's why the width of attached gingiva increases with age and with the supra eruption of the teeth. And we have seen that the attached gingiva terminates at the alveolar mucosa. On the lingual aspect, what happens is the attached gingiva is terminating at the alveolar mucosa of the floor of the mouth. Whereas on the palatal aspect, we do not have a mucogingival line. There is no demarcation in between the attached gingiva and the palatal mucosa. The attached gingiva is firm and it is continuous with the palatal mucosa, which is equally firm. So there is no distinction in between the attached gingiva and the palatal mucosa on the palatal aspect. Now, we have already learned one method of measuring the width of attached gingiva. Now we'll see the other two methods. Another method is roll test, wherein we place a periodontal probe horizontally and we will push the gingiva towards the coronal aspect. The attached gingiva is immovable and it does not move. The gingiva, if it is moving, it means that the gingiva is inadequate. The width of attached gingiva is inadequate. Another test is the Schiller's iodine test. It is a staining method. So in this case, the Schiller's iodine only stains the alveolar mucosa because of the high glycogen content in the alveolar mucosa, and it leaves the attached gingiva unstained. By this, we will be able to differentiate in between the attached gingiva and the alveolar mucosa. We will be able to locate the mucogingival junction by this staining method. Next, we will learn about the interdental gingiva. The interdental gingiva will occupy the gingival embrasure. By gingival embrasure, I mean the space beneath the contact point of two teeth. In the anteriors, the contact is pinpoint, therefore the shape of the interdental gingiva is pyramidal, whereas in the posteriors, this contact point is broad, therefore it assumes a cone-shaped or a tent-shaped interdental papilla. So it will appear like a valley connecting the facial and lingual surfaces. So the interdental gingiva depends on the contact point that is present in between the two adjoining teeth. And the interdental gingiva is non-keratinized. The attached gingiva and the marginal gingiva are keratinized, whereas the interdental gingiva is non-keratinized. So you can appreciate in the picture that the anteriors are having a pyramidal shape of interdental gingiva, while the posteriors are having a cold-shaped interdental gingiva. You may ask me one thing. In the A picture, the second diagram shows that the anterior teeth is also having a cold-shaped. It might be possible when the contact point is shifted towards the apex. I mean, like if the contact point is towards the coronal end, it is pinpoint. But when the contact point is shifted towards the apical end, it will become a broad contact point rather than a pinpoint contact. Then obviously the interdental gingiva will turn into cold shape. So that's why we mean that the interdental gingiva shape depends on the contact point in between the two adjoining teeth. And with the degree of recession also, the shape of the interdental gingiva varies. Suppose there is no contact point in between the two teeth, then what will be the shape of interdental gingiva? This is a very important MCQ. The answer is that there is no interdental papilla itself. The interdental papilla is absent when there is spacing in between the two teeth or the diastema in between two teeth. Next, we come to the microscopic features of the gingiva. Here you need to remember 3 points. There is epithelium, there is connective tissue, and in between epithelium and connective tissue we have the basal lamina. The epithelium has lot of cells, whereas the connective tissue has less amount of cells, and it is primarily made up of collagen fibers and the ground substance. So we told that there are lot of cells in the gingival epithelium. What are these cells? There are actually two categories of cells. Those are the keratinocytes, which form the predominant cell population, and the non-keratinocytes. The non-keratinocytes are again three types. They are the melanocytes, Merkel cells, and the Langerhans cells. Whatever population is formed by the keratinocytes, other than these, the remaining population constitute the non-keratinocytes or the clear cells. The melanocytes and Merkel cells are located in the deeper layers of the epithelium, whereas the Langerhans cells are located in the suprabasal layers or the superficial layers. So here, now don't worry about the layers, we will be learning in further slides, but for now remember that the melanocytes and Merkel cells are in the deeper layers, whereas the Langerhans cells are in the superficial layers. The Merkel cells have the tactile receptors for pressure, whereas the Langerhans cells are called as the dendritic cells, and the melanocytes are especially seen in the basal layers and the spinous layers. Here in the diagram, we can appreciate the presence of the dendritic cell in the suprabasal layer and the melanocytes seen in the deeper layers of the epithelium. Here, I am not showing you the picture of gingival epithelium. I am showing you here the picture of the epithelium of skin. The epithelium of skin is having 5 layers. Those are the stratum basale, spinosum, granulosum, lucidum and the corneum. But in the gingival epithelium, we don't have the stratum lucidum. We only have 4 layers, that too depending upon the degree of keratinization seen. Now, we will learn more about the gingival epithelium. The gingival epithelium was thought to play a very passive role. That is, it was thought that the gingival epithelium only has a physical barrier to infection. But later, research revealed that the gingival epithelium has a very active role in the host defense. The gingival epithelium has the capability of responding to infection. It signals the cell events and even causes the changes in differentiation and cell death. And the gingival epithelium is also responsible for coordinating the immune responses, and it links the innate immunity and adaptive immunity. So now no longer it is believed that the gingival epithelium is passive, but it is believed that it plays a very active role in the host defense. The gingival epithelium is lined by stratified squamous epithelium, and there are 3 layers of gingival epithelium histologically. Those are the oral or outer epithelium, cellular epithelium and the junctional epithelium. Now, here we learn the layers of the gingival epithelium. These layers depend on the degree of keratinization that is seen. So, if a gingival epithelium is orthokeratinized or completely keratinized, then we see these 4 layers of the gingival epithelium. That is the stratum basale, spinosum, granulosum and corneum. The stratum spinosum is also called as prickle cell layer because of the cell appearance, and the stratum granulosum is responsible for the keratinization of the gingival epithelium. The stratum corneum is also called as horny layer. If it is completely keratinized, then the stratum corneum will not have any of the organelles, it will not have any nuclei. But in case of parakeratinized epithelia, the stratum corneum shows the pycnotic type of nuclei, whereas in the non-keratinized epithelia we have a superficial viable nuclei, and the non-keratinized epithelia will not have the stratum granulosum and stratum corneum. It will lack these 2 layers. Now let's try to identify the types of epithelia based on these layers and the features of the gingival epithelium. So here in the first picture we can see there are 4 layers of the epithelium. We can notice the horny layer without any nuclei, without any organelle. So it shows the complete keratinization of the gingival epithelium, and we can call it as orthokeratinized epithelium. The second picture shows us the presence of viable nuclei in the superficial layer. There are only 2 layers, basal and the prickle cell layer. So it is non-keratinized. In the third picture we can see the retaining of the pycnotic nuclei, and it is parakeratinized epithelia. Before studying the features of different types of epithelia, let's understand their locations. So in this diagram, you can see the gingival sulcus. The gingival sulcus, which is a V-shaped depression, and it is extending from the crest of the marginal gingiva to the base of the sulcus, or even I can say from the crest of the marginal gingiva to the coronal limit of the epithelial attachment. The epithelial attachment that is adhering to the tooth surface is called as junctional epithelium. This is lined by junctional epithelium, whereas the sulcus is lined by sulcular epithelium. You can see the 2 dotted lines which forms the sulcular epithelium. Beneath the dotted line is the junctional epithelium, and the remaining part on the outer surface of the marginal gingiva and attached gingiva is formed by the oral or the outer epithelium. So coming to oral or the outer epithelium, it is present on the crest and the outer surface of marginal gingiva and the attached gingiva. It is of 0.2 to 0.3 mm in thickness. It may be keratinized or parakeratinized, but most of the times it is keratinized, and it has 4 layers of the gingival epithelium. And in the diagram you can notice that from the crest to the surface of the attached gingiva, it is the oral epithelium that is present, and in the sulcus there is sulcular epithelium. Beneath the sulcus there is an epithelial attachment that is lined by the junctional epithelium. Now we will learn about the sulcular epithelium. The sulcular epithelium lines the gingival sulcus. We have already seen in the picture that it extends from the coronal limit of the junctional epithelium to the crest of the gingival margin. It is lined by thin, non-keratinized stratified squamous epithelium. The oral epithelium is keratinized or parakeratinized, whereas the sulcular epithelium is non-keratinized. An important point here is the sulcular epithelium has the potential to keratinize if two important conditions will happen. These are, suppose if the bacteria present in the gingival sulcus is completely eliminated, then the sulcular epithelium has the capacity to keratinize, or when the sulcular epithelium is reflected and gets exposed to the oral cavity, then also the sulcular epithelium has the capacity to get keratinized. It only has two layers, that is stratum basale and spinosum. Since it's non-keratinized, it will lack stratum granulosum and stratum corneum. Now you can appreciate again in the picture that there is sulcular epithelium lining the gingival sulcus, and beneath the sulcular epithelium we have the junctional epithelium lining the epithelial attachment. Next, coming to the junctional epithelium. The junctional epithelium is unique and peculiar kind of epithelium in many ways. It is also non-keratinized. In the early life, it is only made up of 3 to 4 layers, but later it increases to 10 to 20 layers. The junctional epithelium is just like a funnel, that is with a wide opening and a narrow exit point. That is, its coronal end is wide. It is made up of 10 to 29 cells, whereas in the apical end there are only 1 or 2 cells, and its length is about 0.25 to 1.35 mm. Again, you can appreciate in the diagram the sulcular epithelium, the junctional epithelium, and oral or outer epithelium lining the marginal gingiva. The junctional epithelium forms the epithelial attachment to the tooth surface. This epithelial attachment of the junctional epithelium to the tooth is enhanced by the gingival fibers. This combination of the junctional epithelium and gingival fibers is a functional unit which is called as dentogingival unit. And there are many functions of the junctional epithelium, some of which are: it forms an epithelial barrier against the plaque bacteria. It has many amount of immunologic host defense components which will help in combating with the bacteria. It has a rapid rate of turnover and it is very protective in nature. Now you can see in the diagram that the junctional epithelium, from its coronal end to the apical end, it is getting tapered, so it's like a funnel shaped one. Now, we will learn about the keratins. Keratins are the proteins that are responsible for the keratinization. So here, there are different proteins in different epithelia. So in the oral epithelium, we have these proteins which are responsible for the differentiation. Those are K1, K2, K10 and K12. K6 and K16 which are responsible for the proliferation. K5 and K14 which are responsible for stratification. Stratification is the formation of layers, whereas K19 which is seen in parakeratinized epithelia. So the oral epithelium is keratinized or parakeratinized, right? So if it is parakeratinized, we see this K19 type of epithelia. Here an important point is that when I say K1, it has the highest molecular weight. When I say K19, it has the lowest molecular weight. So the numbering of the keratins is inversely proportional to the molecular weight. Now we see the keratins in the sulcular epithelium. The sulcular epithelium lacks K6 and K16, that is proliferative type of epithelia, and the junctional epithelium also lacks K6 and K16. But as we have studied that the junctional epithelium has high turnover rate, it should have K6 and K16, but the K6 and K16 are absent in the junctional epithelium, and even the K1, K2, K10 and K12 which are responsible for differentiation are also absent in the junctional epithelium. We notice the presence of K19, but ideally the junctional epithelium is non-keratinized, so it should not have K19, but K19 is present in the junctional epithelium. So in all these ways, with a high rapid turnover, with the presence of different kinds of keratins, the junctional epithelium is a very unique kind of epithelium. Next, we will learn about the development of the gingival sulcus. The gingival sulcus is formed at the time when the tooth starts erupting into the oral cavity. But when the enamel formation is complete, it is covered by reduced enamel epithelium. So, when the tooth starts erupting into the oral cavity, the reduced enamel epithelium gets fused to the oral epithelium. This fusion of the reduced enamel epithelium and the oral epithelium is called as the junctional epithelium. You can notice in the picture that the reduced enamel epithelium and the junctional epithelium are forming a broad band of attachment to the tooth surface, and the gingival sulcus is also formed at the same time when the junctional epithelium is forming. So the junctional epithelium and the gingival sulcus both are formed at the time when the tooth is erupting into the oral cavity. Now we will learn about the gingival connective tissue. We have already seen that the gingival connective tissue is composed of less number of cells, whereas it is composed of more amount of fibers. These fibers are made up of type 1 collagen, whereas the cells that are predominant in the connective tissue are fibroblasts, which form only 5%, but they form the most amount of cellular component. And the connective tissue is made up of two layers. Those are the papillary layer and the reticular layer. Initially, we have seen in the microscopic feature that there is epithelium, there is connective tissue. In between epithelium and connective tissue, we have a basal lamina or a basement membrane. So beneath the basement membrane, there are two layers of connective tissue, that is a papillary layer and a reticular layer. So in the picture you can notice that there is gingival epithelium, there is basal lamina, and beneath which you have the papillary and reticular layers of the connective tissue. The connective tissue is also called as lamina propria. Now we will learn about the gingival fibers. We have already seen that the attachment of the junctional epithelium is reinforced by the gingival fibers, and that is called as dentogingival unit. So the function of the gingival fibers is to make the attachment possible. So they will brace the marginal gingiva against the tooth, and those are made up of type 1 collagen fiber bundles. And when the tooth is subjected to masticatory forces, the tooth starts deflecting away from the force, but this does not happen because the gingival fibers are supporting the tooth. There are three groups of gingival fibers. Those are the gingivo-dental group, the circular group, and the transeptal group. The circular group, as the name suggests, they surround the tooth in a ring-like fashion. They encircle the tooth. Whereas the transeptal group, they are the horizontal bundles present interproximally connecting the two teeth. Whereas the gingivo-dental group of fibers, they are present on the facial surface, lingual surface, and on the interproximal surface also. They are embedded in the cementum and they fan out towards the crest, towards the outer surface of the marginal gingiva, and also towards the periosteum of the labial plate, as you can see in the picture. Now, in the next picture, I want you to concentrate only on two types of fibers. The number 7 is the transeptal fibers, which are the horizontal bundles located interproximally running in between the two teeth, and number 5 is the semicircular fibers. So here the semicircular fibers are running from the mesial side to the distal side, but if it is circular fibers, they will run around the tooth in a ring-like fashion. Okay, no need to remember all these fibers. You just remember that there are three sets of gingival fibers. Those are gingivo-dental, circular, and the transeptal group of fibers. Now coming to the cells present in the connective tissue, the fibroblasts are predominant type of cells. They are helpful in the formation of the collagen fibers and the reticular fibers, and they play an important role in the development, maintenance, and repair of the gingival connective tissue. The other cells seen are the mast cells, macrophages, adipose cells, eosinophils, and the neutrophils. We will see the blood supply of the gingiva. There are three sources of blood supply to the gingiva. The first one is from the alveolar bone. There are supraperiosteal arterioles that are arising from the facial and lingual aspects of the alveolar bone. Another source is from the PDL, periodontal ligament. So the vessels of the periodontal ligament will emerge into the gingival sulcus. There they will anastomose with the capillaries and supply the gingiva. The third source of blood supply is from the arterioles that are emerging from the crest of the interdental septa. Here we conclude that there is a need to study the normal physiological anatomy of every component of the periodontium, not only gingiva. Then we will be able to find out the pathologic features and give the correct diagnosis. And the gingival health is very essential for success of all periodontal treatment procedures. The questions expected from this topic are the macroscopic and the microscopic anatomy of the gingiva. From the MCQ point of view, you have lot of questions from the gingiva, beginning with the width of attached gingiva, the values of the width of attached gingiva, the techniques of measuring the width of attached gingiva, the peculiar features that are seen in the junctional epithelium, and about the gingival fibers and keratinization.